Welcome everybody, and thank you for joining us this morning for the session. My name's Brian Ward, and I'm the CEO and founder of Aroa Biosurgeries. Aroa is a fast-growing soft tissue regeneration company, and we have treated now over 5 million patients with this technology, and over 90% of those procedures have been here in the United States. There's over 30 peer-reviewed publications relating to the use of this technology, and there's 6 commercial products here in the United States that are sold based on this technology. So this is a very well-established technology, very large body of clinical evidence that sits behind it. You know, our technology is based on the ovine forestomach matrix, and that's isolated from the forestomach of sheep. One of the interesting things about New Zealand, it's very isolated, and as a consequence of that, many of the diseases that exist in other parts of the world do not exist in New Zealand. If you look at the Aroa ECM, it has some very unique properties, and I'd sort of categorize them in 2 different ways. The first is structure, and the second is biology. Firstly, if you look at structure, the Aroa ECM has a very porous structure, and what that means is that cells can move into that extracellular matrix very quickly and lay down new tissue. Biologically, this material comes from relatively young animals that are growing very quickly, and what that means is that there's very high concentrations of growth factors and cytokines within this material, and they naturally exist within it. So you start with a raw material that has a very high concentration of these molecules, and what we do is that we process that in a way so that we remove the cells and cell contents from that material, and they are the components that would cause an immunological reaction in people, and we end up with a highly purified material that's very rich in these secondary molecules. During the development of this technology, we've spent a lot of time focusing on a process that is very gentle and minimizes any impact of damaging the extracellular matrix through that process. So we've done a huge amount of characterization of this process and shown that there's very little change between the native tissue state and the state of this matrix at the end of processing. So now we have 6 commercial products here in the US. We have 2 forms of Endoform, the Endoform Natural, Endoform Antimicrobial, Myriad Matrix, which is a product for use in the operating theatre for soft tissue reconstruction, Symphony, a CTP product, which we've recently commercialized here in the US, Myriad Matrix. There's 2 versions of this. There's a sheet form and also a powdered form. And we also manufacture and develop products for a company called Telebio here in the US as well. And this is predominantly for hernia and soft tissue reconstruction. So, you know, there's a large portfolio of products based on this technology. So there's 3 ways that we are providing better access for these products. The first thing is better access for more patients. So an example of that would be our Endoform product. Our Endoform product, you know, it's a product that's coded as an A code, as a collagen dressing, but it's really a CTP in disguise. And so it's an extracellular matrix-based product. So you're getting the benefits of a CTP for the price of a collagen dressing. This is a product that can be used from day one, and so there's no waiting to use this product. You can immediately treat patients with this product from day one. We're also providing access for more healthcare providers. And so what we mean here is that many of these products, the CTPs particularly, are limited to a limited number of healthcare providers. What we've done is open up access to all healthcare providers to use these products. So nurses can apply these products from day one. These products can be supplied, particularly Endoform, through the DME market to patients. Patients can apply these products themselves. So we also have products for the inpatient setting. We have a CT product as well. So what that means is that there's wide access here for all healthcare providers. And then the third thing we're doing in terms of access is making sure that these products are available in many sites of care. So available in the outpatient wound centre, available in the operating room, available in home care as well. So bringing these three things together, we think that there's an enormous opportunity for many more patients, many more healthcare providers, and many more facilities to have access to the power of an extracellular matrix, and therefore use these products much more widely for the benefits of patients.
So I've had to understand and learn about the rumen of sheep. And I think it's really important that we understand this, because if you look at as the sheep swallows, and it's a big fermentation tank, right? So it's an environment that's got more towards an acidic nature. Now, if you've been at this conference for the last couple of days, you've heard us talk about the importance of wound acidity. And so here we've got something that's naturally in an acidic environment. We've got wounds that we know that are not healing because they're alkaline. So let's start matching environments together and then start talking about these components of extracellular matrices within the environment that thrives in its native environment. The other significant component is, so I stopped doing vascular surgery about 5 years ago, but I maintained my board vascular status. So I used to work on blood vessels that were 2 centimeters, right size of your thumb. And then we get down to some smaller blood vessels, but now in wound care, what do we work with every day? Our goal is to get 5 micron vasculature to function, because that's where wound healing is. And 5 microns, just to put that in scope, is 1/3 the size of a human hair, which on average is about 17 microns. So when red blood cells flow through a 5 micron vessel, that's where all diffusion of oxygen and nutrients occurs based on something called Fink's diffusion principle. So unless you have functionality at a 5 micron level, you're not going to have delivery. And so again, highly vascular structures, and then the ability to preserve that structure so you have vascular channels, as I'm going to show on the next slide, is critical to forming the infrastructure that allows rapid granulation tissue development and angiogenesis. So the other unique component about stomachs is there's a high turnover rate. There has to be, because if you eat buckthorn and it tears up the inside of your stomach and it doesn't heal, it's going to form into an ulcer, which ultimately could potentially perforate. Well, the animal's lost. So from a teleological standpoint, the DNA, the extracellular matrix, the proteasomes, the matrosome of all that tissue has to be quickly able to restore. Now think about your oral cavity. Last time you bit your cheek, how quickly did that heal? Really quickly, because you got to be able to eat that next meal, because you got to be able to thrive, especially if we were living 10,000 years ago. So we're taking advantage of something that's got a legacy component to maximize in terms of wound healing. So here's this angiogenic property, and I don't even think this picture does it justice, because where the work is done is well beyond those branches. So think of a tree, a big oak tree that's been around for 100 years. It's the stems that bear the leaves where all function happens, right? Everything else is a conduit to get to that point, but it's at the stem to the leaf. So we're not even seeing, I think, where the 5 micron vasculature is where it's all done. However, given what we're seeing clinically happen in our patients with accelerated angiogenesis, accelerated granulation tissue, and the closure rate, those 5 micron vessels are well and alive and very well functioning. So if you take vascular channels like this that are preserved and demonstrated in peer-reviewed literature to be preserved in this type of structure, how do we know that they then become functional? So in this porcine model, we can see, and you can demonstrate both in vitro and in vivo, that there is reconstitution of these vascular channels such that they become functional. So now you got red blood cells going through, you got platelets going through, all the things you need to lay down the fertilizer because red blood cells, white blood cells, they carry that fertilizer component that maintains endothelial cell health, and then you've got all the structures within the proteasome and the matrisome that help make this up. Now, one of my favorite papers demonstrates this, the 153 different components that are within as proteoglycans, glycosaminoglycans, and all these extracellular components that, don't remember the names, remember the story. If we have the right recipe, yet we have the wrong products, so if I give you a chocolate cake and it calls for salt, it's about a half a teaspoon. 2 cups of salt. So just because you have a lot more syndecan or you have a lot more of another proteoglycan, it doesn't matter if it's not proportionality right for restoring and regenerating that particular wound. So I think proportionality through preservation is one of the very critical things about this product that allows the regenerative qualities, and then synergistically it maximizes epithelialization. So I think that's one of the really important components of this in the story to walk away, and why we have used this. I use this extensively in the operating room. It's right on my operating room cart as Myriad, and then in our clinic as Endoform. Thank you for the privilege of speaking.
So I was an existing Endoform user. I'm our wound clinic director, was familiar with the technology, and in 2018 I was introduced to the Myriad operating room product. So this was my first case. This is a 25-year-old young mom of a 1-year-old and a 2-year-old that had severe diabetes, multiple episodes of DKA, and was actually found down on her arm for 36 hours, creating a compression injury. And general surgery consulted me with the first photo there. This was a very large wound, and the outlines show a pulsatile radial and ulnar artery. This patient wasn't a great candidate for a free flap reconstruction, so I had a challenge of providing better dermal coverage over these exposed arteries. So this is when I placed the graft in the second photo, and my initial impressions is that it handled pretty nicely, was soft, conformable to the wound bed. You can see it initially soaking up the blood in the wound bed. And how I applied it was stapling it to the wound edges and then quilting a couple pieces together with an absorbable suture. I found it to be a little less fragile than some of the other products like the amnion products. And I do use this with negative pressure wound therapy. I think they're very complementary. So as you can see here, at week 1, there's initially already some granulation budding through the graft. At week 4, we have near complete granulation of the wound, just a small area. And at 6, it's beautifully granulated. And she went on to have a successful skin graft reconstruction. I was very pleased. It didn't have any infection. I think it granulated very quickly. And she was very happy, and so was I. So that got me thinking, where else could I use this? I see a lot of pilonidal sinus disease. I see a lot of hidradenitis. These are difficult wounds. This is a 19-year-old college student who presented with his 3rd episode of pilonidal sinus disease. You can see the prior midline resection, and had it for 2 years. And here I thought maybe I could add some additional biology to this wound to combat this inflammatory state. Maybe that could be a way I could have better success. So I quilted the Myriad product to the wound bed with absorbable sutures again to get good apposition to the wound bed. Here he is at 1 week, 3 weeks, and 10 weeks, fully healed after having 4 prior surgeries in 2 years of a draining wound, and now he's back at college, very happy. This patient has Hurley stage 3, tunneled fibrotic disease throughout the entire axilla, extending onto the chest wall and extending down to the arm. So my plan is to resect the disease, leading to this very large wound after the scar contracture from the fibrosis. I don't have laxity to close it, so place the Myriad matrix as a dermal template, and that shows the versatility of this product. It can be a dermal template or it can be an implant. At 4 days, with negative pressure, we're seeing good apposition to the wound bed, a little bit of granulation already coming through the interstices. At 1.5 weeks, it had a great regenerated wound bed with good granulation, robust coverage. She elected to continue with secondary intention healing, weekly dressing changes. And here she is at 6 weeks, nearly healed, with a good range of motion and no recurrence of disease. Then more recently, this was an inpatient consult, and this is a 65-year-old lady with poorly controlled diabetes who was at an outside hospital and had a necrotizing soft tissue infection of the left pubic region, groin, buttocks, and thigh. When I see this patient as a plastic surgeon, I know this is going to require a large, complicated reconstruction with a flap and a skin graft. So performed a bony debridement, culture-directed antibiotics for the osteomyelitis, and packed the Morcell's graft here in that tunnel. And at 2 weeks later, the wound was fully granulated with excellent wound bed prep and allowed me to then perform the large procedure more successfully, which was an oblique rectus flap for the perineum and then a skin graft for the thigh. So I think in my practice, it's been very useful to use as the standard dermal regeneration product for exposed structures, to use as an implant to alter the biology and improve the biology of these inflammatory wounds, to use the Morcell's product for these irregular wound beds or tunneled areas, in conjunction sometimes with the sheet grafts to have excellent wound bed prep for a large plastic surgery. And then in the wound clinic, I can continue on the therapy with Endoform if needed. So for me, it's really the entire circle of care of complex wound plastic surgery. This is the majority of my practice, are these large sort of disaster wounds. And it's really been very helpful as a problem-solving tool to get these patients healed more rapidly. So thank you.
So I want to talk to you about my journey with Endoform. And it really kind of starts with the pain points, because with CTPs, you can only get them in certain spots. It's very hard to get them in long-term care. Where I practice across the continuum in acute care, long-term care, home care. I do assisted living visits. So it's really hard when you have patients who don't have the ability to come to the wound care center to get CTPs. So that's my big pain point, because these people need advanced therapy. Now, one of the other pain points, which I think if we all raise our hands, is how many people find insurance as a pain point for CTPs, right? All of us do. So I was at an SAWC a couple years ago, and I always do the poster hall, and I really love the poster hall, and I actually saw a poster from Dr. Ferreras about how he implemented the Endoform in his VA facility. The paper was published, and it was very interesting. So when he introduced Endoform to the VA, he actually found that his CTP use declined, his wounds actually improved in healing rates. And there's two reasons for that. Well, one, you're doing good wound bed prep, but you're also having early access to really a CTP. Now, that also got me thinking. There's an elephant in the room here, and we call it MIPS, right? So now we have in the Medicare system, we are now looked upon we really started in 2015, but really in 2017, we started looking at how we get paid as we move to a value-based system here in the US. But how will you be scored? Look how the impact of cost is now being increased every single year. And so we all love CTPs, and they work really, really well, but it's going to impact how we are going to get paid as individual providers. And we need to start thinking about ways that we can improve our costs and maintain our quality. So I was actually doing a lot of investigation or research into CTPs because I'm looking at cost and how I'm being evaluated. And I pulled up this AHRQ technology assessment. It was actually done in 2012, and look what I found there. Endoform dermal template, but it's there, and their data is in there. It's really great, and it's unbiased. So the question is, why are we not using Endoform in all post-acute settings? You don't need a lot of training. Anybody can put it on. You've got an antimicrobial form available, And time is tissue. There's no waiting those, magic 30 days that you're required to use. I call that, in trauma, we would call that the golden hour. In wound care, we call it the golden month, right? So we need to capitalize on that. I think there's some unanswered questions here. We don't know about some of the long-term impacts of all the CTPs on cosmesis, and I think it's something that we should be probably looking at because that's what our patients want. And then when we take this product and put it into a post-acute setting such as long-term care or home health, how is that impact on that cost? I mean, what is our economic data? And then we really need to be starting to look at the economic data in those post-acute settings because they've been ignored. I want to share with you this case. He is a hot mess. So if he had, if he didn't have bad luck, he would have no luck at all, right? So he gets in a car accident, not his fault, gets hit by a drunk driver. He's a pair of 17 years. He has lymphoma, 2 types. He has many admissions for neutropenia, sepsis, and he needs a stem cell transplant. He's thinner than a rail, many infections, and he has this dark and stormy course. So he gets osteomyelitis. We throw him on IV antibiotics, HBO, make sure he has good offloading, and now the pandemic hits. So he can't go really anywhere because he will die because he's so immunosuppressed, because look at the drugs he's on. So we finally get him cleaned up on day 45. We had to be really gentle with him because he'd had a number of hospitalizations. And we said, to the insurance company, he needs a stem cell transplant, he needs a CTP. And they basically said, no. After about 8 appeals to the insurance company, still saying, no, we can't get a CTP, we actually put in Endoform underneath our negative pressure. And you can see on week 2, we've already really made some significant gains here. Week 5, he's really improving, and really by week 11, he's healed, and we can get him off to the life-saving stem cell transplant that he really needs. So there's value in value, and it's a value to the patient because they were able to get an extracellular matrix CTP dressing at a fraction of the cost. It's great for the organization because it helps them control costs, and then to us, it actually makes us look good in terms of the cost of care that we're providing. And our patients look at us and say, wow, thank you so much for giving us, a chance to have advanced therapy.